Advice and guidance is the big buzzword in general practice right now, as many of the organizations managing general practice in particular are thinking this is the way that we can help save the backlog, to save patients time and to make sure that people are seen more effectively and efficiently. Well, is that the case? In this episode, myself and Andy are going to discuss the whole concept of advice and guidance from our perspective as GPs, and absolutely want to hear your perspective as well. But is this a way that can help save the backlog and stop it from being a problem for us in general practice, in primary care, and the healthcare system itself? Let's have a look as we tech enhance your primary care and learning. Hello, AGP learners. Welcome to this episode where we're talking about advice and guidance and whether it is something that is useful or not. This is a bit of our discussion episodes following our last update episode that we covered live last time. So make sure you jump in and join us for future live episodes. But Andy, what's your thoughts on advice and guidance?
Yeah, looking forward to getting a little bit deeper on this issue. We began to talk about it at the end of the last episode, didn't we? It's an interesting area. So I guess the reason we were talking about it is that there were two stories that had just broken in Pulse just sort of a day or two ago as we're recording this now. So the first story from 20th of September, NHS England working on major expansion of advice and guidance prior to GP referrals. So this story is referring to the fact that NHS England has been working with the Royal College of Physicians and other clinical leaders to develop a new strategy with the intention of reducing unnecessary outpatient appointments. So that's interesting. And then the day after, there was another story breaking about the RCGP has asked the NHS England not to mandate advice and guidance, and not to make that an alternative to a direct referral from a GP to a secondary care specialist. So those are the stories. I guess to provide a bit of background, we should probably say what advice and guidance is. We often have patients, watching, and they may not know exactly what we're talking about. So I guess my experience of advice and guidance is that this is something that caters for the grey area in between a patient that can clearly be managed effectively in primary care with the knowledge and skills that we have in general practice, and a patient who definitely needs referral for something that can only be provided by a hospital specialist. That might be their specialist opinion. It might be drugs that only they can prescribe. It might be imaging or investigations that only they have access to in hospital, or it might be treatment like a surgery, or something like that, that they are able to provide. And then there's a grey area in between, or has always been a grey area in between, where the GP might be able to manage them if they could just access a little bit more specialist knowledge, opinion, input from a secondary care colleague. And back in days gone by, if we speak to colleagues who, maybe you remember this, Gandhi, I don't think I quite remember it. I could perhaps pretend to, but I don't think I do. But we hear about days where the GP could pick up the phone and ring the hospital, or even ring, the personal number of a hospital specialist, that neurologist that they, were trained in hospital with, or were at medical school with, or, somebody's wife or something like that, to get that input around that patient. But those days are gone. Obviously sounds very old fashioned. And there wasn't really anything to replace that. And then a few years ago, advice and guidance started to be available. And that's where you can write what is normally now an electronic message to hospital specialists, providing information about the kind of dilemma that you've got. And they write back to you. They provide some advice. And, sometimes the question is, do you need to see this patient? And they'll write back saying, yes, we do. Or actually, no, we don't, do X, Y, and Z instead. So that's my experience of what advice and guidance is. And it sounds like they're talking about taking this to the next level. I mean, what's your explanation for people about what advice and guidance is? Have I done it justice, or would you add anything to that, Gandhi?
No, very much that kind of description. I know when I explain it to patients when I do use it, I will say that what I can do is I can send all the information you've given me and from my understanding of it to the specialist, and hopefully they can come back with us with a plan. That may be that they need to see you, that may be that they suggest other things that are more effective to do in your situation, because I'm not quite sure whether we do need you to see the specialist. And actually this may be a more effective way and a quicker way to get that advice. And I think that's the key thing right now, isn't it? So when advice and guidance came into effect, a lot of it was more about trying to be that supportive tool to help clinicians understand the journey of the patient more effectively. Now, because of the backlog, unfortunately, it is often seen as one of the only real ways of getting timely advice, not quick advice, but timely advice of how to support a patient. Because what we don't want to be doing is actually referring a patient inappropriately to a clinic where, to be honest, nothing may happen. But actually now it's become part of the whole journey of the patient, because actually it's the only way sometimes we can get information about what to do next with the patient, because the patient is struggling in the meantime. And that's really complicated when you know that the outpatient appointment is the only real option. But what about if you could just do something in the meantime to help them, then it can be sometimes a really effective thing. And I think it definitely works better in some specialities than it does in others. And it's important to recognize that. I think there's also the element of how well those specialists engage with it compared to when they don't.
Yeah, you're beginning to explore some really important points around this, I think. The first of those were you were highlighting the context that we're in. So there are big backlogs in all parts of the NHS, in particular, outpatient waiting lists, for first appointments and for follow-on care with those clinics. So that's the context. So I think NHS England, will be looking for anything they can do to help with that situation. And this is obviously something that's in the toolkit that they're evaluating the effectiveness of. And then also you say, it's good for some. It lends itself more to some specialities than others. So quite visual specialities like dermatology. There's quite a good local service, called Telederm, where, that is specifically for pictures of rashes and skin conditions, along with some other history and context to that to help, support diagnosis and treatment. Works really well for dermatology, I think. Other specialities, perhaps less so. And also you say it depends on, how it's handled as well. Often you get quite thoughtful replies from named people and doctors within the system. Sometimes you feel like maybe you've got a kind of cut and pasted response from a frequently asked question document that doesn't feel particularly personalized for that particular patient. So it can be quite variable as well. Just picking up some numbers that I thought were interesting within the first of those articles. They were saying that according to data from NHS England's Specialist Advice Activity Dashboard, there are around 200,000 pre-referral specialist advice requests in July 2023 alone. And of the 150,000 that were received and responded to, that's interesting. What happened to those? What happened to the 50,000 that were not received or responded to? Well, okay, who knows? 70,000 did not ultimately result in a referral. It's interesting because they kind of the implications of how they're presenting this. So that actually, you might look at this and think, half of the time, when the GPs contact the hospital, they didn't need a referral. If we expand this, we can reduce the number of referrals. Can we reduce the number of referrals by a half, for example? And I don't think that's the right logic to apply, because a lot of these queries, perhaps the expectation wasn't necessarily that they were going to be seen in secondary care either. It's about advice and guidance. It's not a referral. So I just worry that two things are being confused here. The need for advice and guidance to manage patients effectively in primary care when GPs don't expect they need to be seen in primary care, which I think was the original purpose, with the management of referral triage and managing the number of referrals that go through, which I think is something different. And there's a place for referral triage, but we call it referral triage. We don't call it advice and guidance. So I really hope that we don't end up with a very confused solution that's misnamed here. Yeah.
And I think, primary care has seen a huge element of that, referral triage element already. So already for many specialities, there's pre-referral criteria in terms of things you have to do before you're allowed to refer a patient. You also have many conditions are now excluded from referral. So things that we're not allowed to refer for, but the general practice is asked to manage that challenge without any other outputs. And obviously the people who suffer in those situations the most are actually the patients, because then they don't have a service that can help them. So that makes it even more complex and stuff. And like you say, it's that question of those kind of numbers that they're talking about. if the intention wasn't for a referral in the first place, which is actually what we're saying, then actually it's served its purpose and it's working really effectively for those 50% who weren't seen, because that was the whole point. They were being asked for advice as to how to manage this case effectively so that they do not necessarily need to be seen. As you mentioned, turning it into a referral management system, which is what seems to be the flavor that they're talking about, just really doesn't speak well. And I guess the big concerns that many of us have within the profession is, what does this mean in terms of the output of that workload, which I think we probably need to talk about at some point, don't we?
Yeah. So I guess before we go there, I was just going to add, if the intention is referral numbers management,
Mm-hmm.
there are other ways to do that, which I think are a little bit more direct and get straight to the point, really. As you say, there are some conditions, there are some treatments which, are no longer available, which we can't refer for. That's a
Mm-hmm.
way to reduce the number of referrals. And actually, locally in Nottingham, I think we have quite good availability of the documentation around local referral pathways that allow
Mm-hmm.
GPs to quite easily use a computer system to identify what should be in place before a patient is referred for a particular condition and what criteria they should meet. And that the GPs should put those things in place before they refer. And I think actually the awareness of that information is quite good now amongst GP colleagues. But I think those sorts of mechanisms are ways to reduce unnecessary referrals. I'm not quite sure that certainly mandating that all
Mm-hmm.
referrals are screened before they go through to secondary care is the right way to go about it. Yeah, you were going to talk about workload, Gandhi. God, lead us in with that.
Well, I think it's something we have to talk about. So important to recognise that whose responsibility is it when that patient has been referred? So often when general practice will refer a patient to secondary care, we pass on the information and the appropriate journey for that patient, and therefore they now need to be seen by that outpatient clinic. And absolutely, general practice continues to support those patients until they are seen in that clinic. But you've kind of reached a threshold. You've reached the limit of what you can actually do. So part of that responsibility is now also that service in terms of how they will manage things and stuff. With advice and guidance, that seems to be that responsibility is not held jointly anymore. It is still individually held by general practice. And then what about the output? So as we heard, about 50% of the referrals that were received, you're right. What happened to those 50,000 that weren't received? God knows. But 50% of them that weren't received did not end up in an outpatient clinic appointment. But that doesn't mean that they didn't have further journeys for those patients in terms of what happened. So they may have had further testing, they may have had further investigations in terms of things like scans or other kind of things. They may have been recommended to try further treatments that actually may not have been appropriate at that time because the context wasn't correct. Because the other thing to remember that one of the reasons why clinicians refer from primary care to secondary care is also for a second opinion. And that opinion is very much coloured by either the information you receive through the paper referral, or is it better coloured by actually seeing and talking to the patient yourself? And that's one of the reasons why we often take histories repeatedly from patients when they journey through their healthcare parts. It is because somebody else may pick up a different perspective from the way that they inquire to that patient. And are we losing some of that with the workload aspect of it that then changes the output for the patient? Does that make sense?
It does, yeah. And I think it sort of supports a point I was going to make as well, which was the cynic in me thinks, well, if you've got a problem with waiting lists being long in secondary care, a way to make those figures look better would be to shift rather than those people sat waiting to be seen in secondary care. Maybe they're sat waiting for some advice and guidance to be received from the GP, and they're not actually appearing in those waiting list numbers. Maybe actually some of what might have traditionally been done in terms of initial tests and initial additional history taking in secondary care might then come to sit with general practice as additional work, but also as a patient that isn't sat on a waiting list whilst they wait for an additional blood test or some additional paperwork to be completed by the patient prior to being referred. One wonders if this is about erecting some friction to referrals that will help the numbers look better. That's the cynic in me. That being said, A&G done for the right reasons and for the right objectives, I think is really, really helpful for patient care. But we just have to make sure that we're not conflating the function of A&G, advice and guidance, with other things that we want to improve. So yeah, I just think we have to be careful, really. Another point, Gandhi, is I just worry about the optics of these sorts of statements and headlines, because it's quite easy to present this in a way that, oh, GPs are making unnecessary referrals. Even that language around unnecessary referrals, implies some deficiencies in general practice. And I'm not sure that really that's what this is actually about. I think this is about secondary care capacity, and I think it's potentially about doing things a bit better and supporting GPs to look after patients in primary care better. But the language around this, there's a risk that it turns into sort of GP bashing, at least when you reduce the issues to headlines and they start to get in the lay papers, as they might do in the next few weeks. So I just worry about the optics as well. I worry about the intentions and I worry about the optics. But there might be something positive at the root of all of this.
And I think there's also that discussion that needs to be had about the resources. So we talked about the workload impact that this has, both for primary and secondary care in terms of doing it. I think it's important to recognise the resource changes that may need to happen if this was to be pushed even further, and possibly even the resource changes that need to happen already as the system continues to exist. So, at the moment, if the practice does that referral, they may have additional work that comes back from that guidance. And those are resources that have been used by primary care, which has saved resources in secondary care. But then actually, is that shared? Because it should be. Let's be brutally honest about that. If there are cutbacks, savings that are made in terms of outpatient clinic appointments, because an outpatient clinic appointment is really expensive. You're talking at least about, £150, £200 for an outpatient clinic appointment, for the cost of that to the system. Actually, if that's being saved, where should that saving be shared to? Many people would absolutely argue that primary care should receive some of that resources for carrying that workload, for helping make that savings. And in some places that has happened. So some LMCs and some locations have actually negotiated a rate of pay for doing advice and guidance for their general practices, which actually helps to provide those resources, which means that they're not taking away that care from patients in other ways. And that's a gain share agreement. That would seem really sensible and appropriate to do. But let's be honest, we know that many places will not do that, will they? I mean, actually, that doesn't exist in Nottingham. Advice and guidance was brought in with a view to saving the patient journey, but has absolutely increased the clinician workload in primary care, and to a degree even in secondary care, because it's a different kind of workload that they now have to do.
Yeah, absolutely. The gain share agreement, that's a really interesting point. I mean, because as you say, if if something is now not being done in secondary care because it's being done in general practice, well, that general practice GP or staff or resource can't be used to do the general work of general practice. So in those circumstances, it would be right for resources to move. Another aspect to this is I think people have to be careful what they incentivize or ask people to do, because just a personal story from practice. I remember talking to a colleague a few years ago when advice and guidance was fairly new in Nottingham, and the sort of messaging around it was, we want you to send advice and guidance. We want to drive the use of this. And this person thought, okay, right, well, then I guess I'm being told that before, for just about every referral I do before I refer, unless it's a 2-week wait or a very urgent referral, I think the system's telling me that I need to send an advice and guidance. And they sent a lot of advice and guidance, and then that showed up in the local statistics, and they got talking to about it. Or it was, it was actually they didn't want quite that many, and they were overwhelming the advice and guidance pathway by behaving in that way. So I think you have to be careful and make sure that actually the resources in place to deal with all of that advice and guidance. Further, go on, Gandhi. I've got one more.
After you.
Now, I was just going to make, and also you have to be careful about the quality. The quality. If you, the quality of what comes through can go down if you ask for more volume. Because I know as we make it easier for patients to contact us in general practice, actually the bar for people asking their GP a question often goes down. I don't mind people asking us questions, but sometimes if they've just had a cough for for a few hours, as occasionally happens. You think, well,
Yeah.
you could have probably waited a little bit longer, before contacting the GP. So as you reduce the barrier and encourage people to communicate, sometimes you get more communication than you actually want. And I do wonder if the quality of the questions that GPs might be asking in advice and guidance might go down. It's actually it's a way of sharing responsibilities for decisions that a GP could potentially take on their own, but it might just be irresistible to share a little bit of that decision and that risk with secondary care if that's open to you and you're being incentivized to do it. So I think we just have to be careful about that. Sorry, Gandhi, I think you've got to come in on a point though.
I forgot what that point was, but I've got a backup one from what you just said. So I guess, I've seen that with the hematology service. So hematology is actually a really good one to work with advice and guidance, because often it's about understanding the numbers for the patient's blood test results in combination with their symptoms. And is this something we need to be more worried about or less worried about? And how do we manage it? Because some of that may be managed more effectively from primary care. But actually that reduced the tolerance of needing to ask the question. So I saw many of my colleagues then started to ask much more simpler kind of questions, particularly a lot of the newer colleagues to general practice, about hematological-based questions, because it is a little bit complex, but actually there's really good guidance out there that we're provided with. And then the response from that was very much that the services, when they were replying back, were saying, as it says in our guidance that's available here, this is what you should have done in the first place. And trying to make that more of a clearer journey to help educate people in terms of what could be possible. I think that also, though, speaks to the other prospect of how that advice can be given, that actually sometimes you get templated answers, sometimes you get information that is just, you can see hasn't really addressed the question that's being asked. And I think that aspect also needs to be considered with advice and guidance, that actually when we are asking for opinions and we're asking for advice, it needs to be taken appropriately. And I can give you many examples where I've asked questions about treatment options for a patient with a little bit of complexity that didn't necessarily need to be seen in clinic, but I needed support in terms of understanding that patient's treatment. I outlined the treatment that's already happened, and the advice came back to use exactly one of those things that I've just mentioned that we've already tried. And it says so much about the process that actually this hasn't been considered. It's a template structure. And you mentioned one of the other points earlier about the responsibility of the answers as well. So I know some of the specialities, you'll get a named clinician who is happy to put their name across the advice that they've given. Some of them will just say service. And the problem with that is often those ones are very much you're questioning whether it's a clinician that's given that advice or whether actually it has even come from an administrator. And I have had examples where that's happened before as well, where it has been an administrator who's given that advice. And that clearly should not be happening, because what's the flubbing point if that's the case?
Yeah, and you're right. And this is where that line between referral triage and advice and guidance, I think, needs to be really clear, because I think we now expect that referral triage may well be done by an administrator without clinical training. And often what they're doing is saying, okay, has this blood test been done? Has this X-ray been done? Does it meet the minimum information standard for a referral, as a starting point before it goes through? And I think we accept that happens with referral kind of triage systems. Advice and guidance, I think you're asking for advice, you're asking for guidance. So it really needs to be someone who is more experienced in that field than the person asking the question for it to serve any useful function as named. So I think we just have to be careful if there's an expansion in this service, that, if actually what they want is referral triage, then call it that, and fine to use administrators. But, if we have advice and guidance that's not done by clinicians because there aren't enough clinicians to man the expansion, I think that would be a negative thing.
And it's interesting, Andy. So me and you have actually been through a similar journey locally. One of the healthcare services in Nottingham actually fully moved to a advice and guidance only method as the route in for patients to be seen by that speciality. And actually, that was really negatively received, both by the profession, but also by patients, because we could no longer refer patients directly to the outpatient clinics. It was completely taken away from us, because it was mandated that every patient should go through advice and guidance before they refer to the clinic. And then they would decide whether or not that patient should be seen in the clinic. And the problem with that is that the compounding aspect was, the advice was based on the information you presented. Well, actually, like I said, sometimes you want that collateral secondary perspective, the second opinion, the history and that kind of stuff.
Yeah,
But
that's why
also,
outpatient first appointments are longer than 10 minutes, right? It's
exactly, that's
so
why
that
they're
they can
30
collect the
minutes,
necessary
potentially an
information.
hour, all that kind of thing to establish that. But also, what then also happened is that everything was sent through that. So actually, it was delaying the patient journeys for certain conditions. And actually, were we missing diagnoses because actually that was part of the challenge with it. So I think we've seen how it can work. And I think certain specialties, like we talked about, can be really effective. I think we've also seen cases where it hasn't worked and it should not work as a referral management process, as you've mentioned as well. But that's the worry, isn't it?
We'll have to see. I'm always worried when we talk about doing something en masse, doing the same thing across the country, because there are places that are set up really well for things to be successful, and the places where they're probably not ready, for it for all sorts of reasons. So I do worry a little bit about this, but I think advice and guidance in general is a good concept. And that last point you were making, Gandhi, I think brings us to the place where it might be a good place to end. Really, is like back to the patient. Because this can potentially, be actually quite helpful for patients. As we were saying at the beginning, if it enables the GP to get access to specialist advice, specialist guidance to manage them more effectively, in primary care, not having to wait for a secondary care appointment or to manage them while they're waiting, that's fantastic for the patient. If it becomes a little bit of a turf war between primary and secondary care with patients stuck in the middle, having to wait longer for what they need, that's a negative, isn't it? Looks like you had another
Absolutely.
point, Andy.
I do. So just before we wrap up, actually, I'm going to introduce potentially the next version of advice and guidance, what I think should potentially happen. So video consultation was seen as the panacea of general practice, wasn't it, Andy? And actually it kind of fell flat on its head because the realization that it didn't work as well. However, what about joint video consultation between primary and secondary care as your outpatient experience via an advice and guidance method?
Wow, it sounds like there might be a video coming on this, Gandhi.
Maybe. Yeah.
Interesting concept. I'm eager to learn more, and will reserve judgment until I know more about it, Gandhi.
Well, if you would like to know more, feel free to check out this episode that I've recorded with Dr. Rebecca Payne, where we talked about video consultation in general practice. And part of that, we talked about what I think is the future evolution of video consultations. And I think with outpatient clinics is where it is at. So why don't you go check out that episode? Alternatively, check out this one right here as we continue to tech enhance your primary care and learning. Catch you later.